I'm Norma Loeb, founder and executive director of the Lewy Body Dementia Center. I'll be back with you in a moment, but right now I want to introduce to you first Dr. Belinda Miles, who is president of Westchester Community College and is welcoming all of you. Thank you.
Thank you, Norma, and good afternoon, everyone. I am indeed Dr. Belinda Miles. I am from Westchester Community College, where we are less than 20 miles away, but far more minutes in the commute. And on behalf of the State University of New York Chancellor, Dr. Christina Johnson, and my colleagues at SUNY's 64 colleges, research universities, medical centers, and community colleges, welcome. And thank you for attending today's Lewy Body Dementia Symposium here at SUNY's Global Center in New York City. SUNY not only educates nearly 1.3 million students, our campuses also provide outreach programs to the community so that we can serve the needs of the very diverse individuals in the regions where our institutions sit. At my own campus, we recently had a wonderful community outreach program sponsored by AARP in association with the Alzheimer's Association of Hudson Valley and the Westchester, New York chapter of the Links Incorporated, a women's service organization. It was a seminar that focused on various types of dementia and was well attended by medical professionals, caretakers, and families. So it's something that we thought was remarkable in terms of the attention that we were able to garner on a Saturday morning in Valhalla. And so I believe that in that session, the researchers focused on some of the genes that have been identified that pharmaceuticals have the potential to target to treat individuals with various types of dementia. And so forums such as that one and this one today are opportunities to give information, to bring awareness, to educate, and also to support families and those who are affected by these life-altering diseases. They are our faculty, our students, civil servants, institutional leaders, and many times even ourselves. Throughout the SUNY system, we are training tomorrow's leaders and innovators, and perhaps the researcher who will discover a cure for debilitating diseases like Lewy body dementia, Alzheimer's, and other related diseases. We're encouraged by the work of those of you who are leading the charge. We thank you, Norma. We thank others who are joining you in this effort. And we know that there are not only those in research laboratories, but also those who work quietly and often without recognition to provide care or to coordinate care for others affected by these diseases. So thank you once again for putting together this symposium. I wish you every success. I regret that I won't be able to stay throughout the entire afternoon, but I wish you all the best in your learning and in your sharing. Thank you. Back to Norma.
I'd like to give you some background on how the Lewy Body Dementia Resource Center was founded and the reason for it. My mother had Lewy body for 18 long years, which is not the norm. I don't know how much all of you know. Can I remove this at all? Okay. I don't know how much all of you know about Lewy body dementia. I know you've all heard of it, but I have a feeling that you'll learn a lot today from Dr. Shanker and from Dr. Dewan and from the film that you'll be seeing later. The Resource Center was founded because in New York, thank you, there was no place else for people to go. There's only one other organization in the country for Lewy body dementia. We are the only one in the country that have resources, not only of doctors, but we have neurologists listed and geriatricians for every single state in the country, as well as 15 other countries. We also have resources in New York, California, Florida, and we're adding some others day by day that have information not only on physicians and physical therapists and meal deliveries, veterans information, every single aspect of caregiving on music therapy and art therapy. We want to be able to help as many people as possible, and that's why this organization was founded, because there was nowhere else for people to go. My hope is that as you come across patients and people with the disease, that you will send them to us. We work tirelessly to bring support and love and awareness constantly, because all 5 of us who founded the organization, and 2 of my colleagues are here today, Marissa Stefatos and Susan Visconti, all had parents who passed away from this disease. We have the only live helpline in the country for Lewy body dementia, and we now have 5 support groups in the New York area. For those who think that Lewy body dementia is rare, it is not. It's the second most common form of progressive dementia after Alzheimer's disease, and there are more people who have it than are HIV positive. There are more people who have it than have ALS, muscular dystrophy, and cerebral palsy combined. But it's consistently misdiagnosed, and I can tell you that I've been leading the only support group in New York for 12 years, and though I think it's getting much better, there are people being misdiagnosed constantly. And I think you all know that the reason that it's so important for people to be diagnosed correctly, even though there's no cure for Alzheimer's or Parkinson's or Lewy body, is because people with Lewy body are extremely sensitive to medications. And we can talk a little bit more about that later. But they can get much worse. They can get hallucinations from medications, and sometimes it can be fatal. And so we work tirelessly to bring attention so that does not happen and people don't end up in psychiatric hospitals. So why are we here today? I'm so thankful that all of you are here as part of a first symposium that we're ever doing. I'm very thankful for SUNY for collaborating with us. Our hope is that together we can encourage research, find ways of helping people with the disease and with the families dealing with it. We are going to have roundtables to discuss as much as we can and bring new ideas. And then following that, we'll have a lovely reception. And then the screening of Robin's Wish. This film is a brand new documentary about Robin Williams and the last couple of years of his life. It's the first film that ever mentions Lewy body anywhere. And I think it will give you a whole new perspective on what people who have this disease go through, and particularly what families and people go through when they're misdiagnosed, because he never knew he had the disease, and it was found out only after autopsy. So I thank you all for being here, and now I'd like to introduce you, Dr. Dewan. Thank you.
Thank you all for being here. We are delighted to see the response and looking forward to the movie. I was actually going to just emphasize again how common the Lewy body disease is, how honestly we misdiagnose it more often than we diagnose it, and how we mistreat it because we misdiagnose it. I think Norma was being kind. She sort of asked, can I be blunt? And I said, please do. But she was kind to us by leaving out her own personal story where it did not work out very well. So I think it's particularly important that we do all of these things well. So I'm going to actually summarize what the afternoon is going to look like. We have 2.5 hours together and want to make the best use of it. So the first is, I'm really, really pleased that SUNY is doing what SUNY does best, which is use all our resources to move things forward. And in that regard, I think today is a special day. As Norma said, this is the first collaboration, and I have to give a shout out to this special events has been coordinated by, and actually I think the instigation was by Johanna Kendrick Holmes, who is she's the director of the New York program here, special events. And so again, thank you, Johanna. This is really a huge step forward. And it's also nice, I don't know, how many of you have been here before to this facility? 2, 3, 4. Wow. not a lot of people. I've been at SUNY for 44 years, and this is the first time I actually heard of it. And so Johanna has been... But now that we know, we'll be back. So we're going to be trying to doing a few things here. The first is get some inspiration from people like Norma and her group. I'm glad that 3 of the 5 founders are here. But Norma, what you have done is truly an inspiration. Lewy body was sort of described 100 years ago, and it's now that we are doing things like this. So for the fact that you started the first resource center is pretty impressive. It's very impressive when someone does something for the first time. So thank you. You are an inspiration, and we hope we can work with you to do much, much better for our patients. There will be an update, I think, again. There's a lot that we don't know, and we are fortunate to have Vicky Shanker here, who's an expert. And I think she's going to walk through all the sort of the facts and the figures, and hopefully she will be blunt and tell us all the things we don't know. And third, we will hear from a family member along with Norma. So there'll be 2 family members really emphasizing that, as with most diseases, Lewy body disease hugely affects not just the person, but the whole family. And I think that's a very important message that we need to keep in mind. So those are the 3 things that we hope to sort of present. And then after that, there will be time for sort of roundtable discussions. You'll have half an hour for each table to discuss what we can do to move this forward. And I was going to suggest sort of an outline for that. I believe that when you look at medicine and treating our patients, I like breaking it down into start with science, add some art, and don't forget to toss in some poetry. Because when we don't know what we're doing, poetry sometimes helps. So I'm going to challenge each table, each group, to spend a half an hour to give us what is your best idea of science? What should we be doing to move forward in terms of better diagnoses and better treatment? You heard, even in the brief description from Norma, we didn't do very well with either one of them. So what can we do to move the science forward in both those areas? The art, how do we communicate what we do know? Even if it's very little, how do we communicate it to the doctors who keep missing Lewy body disease? How do we sort of communicate? And again, I'm going to challenge Dr. Shankar to help us. I note on her biography, she won an award for communication. So help us. How do we do better? But we do need to do that. And I can tease doctors, we are educable, but sometimes it takes a while. Sometimes you got to be hit on the head pretty hard. So that would be the second. I would love your ideas about how can we socialize what we do know. And then the poetry part, we're going to challenge each group to come up with a great, big, bold idea. What would you like to see? What can you think of that will sort of move the field, not just incrementally, but a whole lot of steps forward? So that's the challenge that we're going to give each table. And we were also keen not to have this sort of be the end point. We had an interesting afternoon, we'll see an interesting movie, and then we can go home and forget about it. So to keep the momentum going, we will send you a list of everybody who is here and send you their emails so you can contact people who you were interested in talking with further. And we'll also send you a summary. And thank you, Vinny. She's going to sort of be the scribe. We'll summarize it so that it won't be like 500 pages, but a summary of a couple of pages of the highlights, and then we'll leave it up to you to collaborate. But we hope that there will be further collaboration. We hope that we can move this forward and that you will meet people who you've not met before. So there's a great deal of interest. I think more people will be coming. And so, again, that's the agenda, and we hope we will do well. Again, thank you very much, Norma, for organizing this. It's my pleasure now to reintroduce Vicky Shanker. Now that we've sort of set the goal very high, please come and live up to it.
No pressure.
No pressure. Dr. Shankar is an assistant professor at Mount Sinai. She actually something that impresses me more is she's the director of their training program, specialist in movement disorders, and obviously very, very familiar with Lewy body dementia.
Hi, thank you. Thank you. So I actually am the clerkship director for the medical students, and I'm the program director for the residents, and I work with the fellows in movement. So hopefully if I say something that's maybe on a neurologist level and that it's not something that you've heard a term or something like that before, just like raise your hand, and I'm more than happy to like re-explain anything. And I'm condensing all of an entire disease into 30 minutes. So I will do my best. And I did kind of put up some of the thoughts and questions for you that have come across, you know, from our body of knowledge of Lewy body and our experience, these sort of looming questions in the disease. And I thank Norma for inviting me today. I thank all of you for coming to talk about this really important disease. So I'm going to start off with just making the diagnosis, which is very challenging. And some of it is really based nowadays just on the clinical diagnosis. That's how doctors are taught, because that's what we have. The clinical diagnosis is made by criteria by an organization. And so they have symposiums, Lewy body symposiums. And I'm going to start off with just a little quick example of a patient that I had a couple of years back. He was 64 years old. About 11 years before I saw him, the wife noted that he was talking in his sleep. Didn't really bother them, but sort of looked like he was acting out his dreams a little bit. About 6 years before I saw him, he started to develop both motor and cognitive symptoms around the same time. The motor symptoms didn't bother him too much. It was a little bit of a hand tremor, and he noticed that he had some dexterity issues. The wife was the one who noticed that his arm wasn't swinging, and family members felt like his facial expression wasn't so great. But that didn't really bother him. And at the same time, he had some difficulty multitasking. He was still working. There was no problems at work. He just felt like it took him a little bit longer to complete tasks. Then about 2 years before I saw him, the main issue was that his cognitive symptoms started to worsen very significantly. So he had to stop working. He actually himself decided to stop driving because he thought he would get lost on the way home. And that he really felt like he was fluctuating, and family would say there'd be times where he'd feel really clear and in the moment and in conversation, and then there'd be other times where he would just be confused and sort of sleepy and out of it. He had mostly illusions. So he would see, like, if a jacket was hanging over a chair at night, it looked like a person to him. And there were rare times where he had very specific hallucinations. And at this time, he wasn't on any medication. And he was sent for a DAT scan, which is a dopamine transporter scan. It's a functional imaging test that looks to basically say, is the dopamine low or normal in somebody's brain? And he had a positive test, at the time diagnosed with Parkinson's disease. So how do we make the diagnosis? The most recent diagnostic criteria came out in 2017 with slight adjustments to prior diagnosis. So the one thing you have to have is cognitive decline, and it has to be a dementia that is interfering with our ability to work or maybe social situations or do all of their activities of daily living, but it has to have an impact in some way. Now, having a prominent or persistent memory impairment is something that happens in diffuse Lewy body, but it may not be the first or most prominent symptom. So it's not like Alzheimer's where patients very early may have some memory problems. This is something that can be seen later down the road, but is characteristic in the disease. But even more often seen, but maybe sometimes harder to pick up, is that They have attention difficulties, they have executive function difficulties, so that's sort of like organizing things or multitasking, and visual spatial difficulties as well. So one of my patients, for example, kept going to the right of his martini class in the evening, just missing it. It was one of the first things that his partner started to notice. So you have to have more than just this essential feature. To have a diagnosis of probable Lewy body, you need to have at least 2 core clinical features. The first is that fluctuating cognition, so times of clarity and times of fogginess. Sometimes it's sleepiness, or sometimes it just seems of confusion, and again, times of clarity. And that can be hours, it can actually be days, but there's times where they're clear. Or you have to have recurrent visual hallucinations. They're usually not on medications that are causing these things. And the visual hallucinations tend to be very well formed. People, children, there's detail in those hallucinations. They can have REM sleep behavior disorder. REM stands for rapid eye movement. So that's your lightest phase of sleep. And so that's normally if you see somebody dreaming, how you can see the eyes fluttering, but you actually don't move during that time. You're typically atonic. So you may move during other times of sleep, but not during dreams. That's protective. These patients, sometimes they're like chasing the bear. Maybe they get the bear and what they're doing is choking their wife. So it's actually really important to ask those questions, because sometimes you find out that the spouse moved to another bedroom a long time ago, and you ask how the sleeping is and they're like, fine, but she moved because he was hitting her or strangling her or talking. So that's kind of the flavor of REM sleep behavior. And then Parkinsonism. So typically that slowness of movement, rigidity or tightness. The rest tremor is less common in Lewy body than it is in Parkinson's, but it can be present. They just may have the mass facies or shuffling gait. And so again, it's only 2 of these things to make to make the diagnosis of a probable Lewy body. I should add, since we brought up pathology, that definite Lewy body requires autopsy. So in life, a doctor's probably not going to say it's definitely Lewy body. However, we're going with a probable or possible diagnosis. So for probable diagnosis, you only need to have 2 of these core clinical features. And actually, there are some patients who don't have Parkinsonism, and studies show that these patients take the longest to diagnose, because we kind of are looking for those 2 features together. Now, that's not the only way that we can make a diagnosis. There's indicative biomarkers, and again, none of these are specific. And in fact, from a movement standpoint, a lot of these I find not very helpful. I think if a dementia specialist was seeing patients and trying to determine between Alzheimer's and Lewy body, these are helpful. A little less so, I think, in Parkinson's. Why? Because I can have an abnormal DAT scan in anything that makes dopamine low. So Parkinson's disease, progressive supranuclear palsy, multiple system atrophy, cortical basal degeneration, frontal temporal dementia. So when a patient comes in with a positive DAT scan, it's not very meaningful to me if I already see clinical features of Parkinsonism on examination. Then you can use this myocardial scintigraphy. It's a sign of autonomic dysfunction. But we often see that in multiple system atrophy, and you can see there's a host of medical conditions that can also cause abnormalities on this test. And the REM sleep behavior that I told you about, aside from just getting a historical picture of it, you can send them to a sleep lab and you can document that. So you can use that as part of your assistance in making this diagnosis. So if somebody has 1 core feature or 1 or more of these indicative biomarkers, you can also make a diagnosis of probable Lewy body. Now there's a whole bunch of supportive clinical features that the consortium published. And again, they're not specific to this condition. We see this in a lot of movement disorders and problems. And Norma brought up something very important, is that sensitivity to antipsychotic medication. Actually, if we want to give doctors any credit, they They downgraded this because it used to be in the core, but so many doctors have now realized that it's not a smart idea to give these patients antipsychotics. We don't commonly give people we see with Parkinson's disease, even if it's Parkinson's, antipsychotics. That is just not something that's done very often, so they dumped it into the supportive clinical features. And they added in these new criteria, these hypersomnia periods of excessive daytime sleepiness into this category, which wasn't there before. Postural instability and having lots of falls is not something that we see in early Parkinson's. This is something that we typically see 10 years down the road. So if somebody comes into the office in the first couple years with postural instability and falls, we are thinking about atypical Parkinson's conditions. Having abnormal smell happens in a lot of neurodegenerative conditions, so not specific. Certainly other types of hallucinations, tactile hallucinations, are something that can be seen. Again, supportive but not specific. Apathy, anxiety, depression, all of the neuropsychological profile that we have to think about in these cases. And there's some supportive biomarkers. So again, I think these are a little bit better when you're comparing to Alzheimer's, because Alzheimer's you see temporal lobe atrophy, and we don't see that in Lewy body on imaging. PET scans, actually, we can see some abnormality in the occipital lobes in Lewy body, which is sort of that visual spatial abnormalities that patients have. And the EEG having slow wave activity, which is sort of just a sign of general dysfunction in the back of the brain. Again, that visual spatial posterior area. So you can make a diagnosis of possible Lewy body if you have you have to have the essential feature of dementia, but then one of those core features that I brought up with no biomarkers. So again, it's probable if it's two or more clinical core features, or if you have one indicative biomarker and no core features, it's possibly Lewy body. So again, this is the criteria that we have to work with in the office. So there's problems, right? And I'll tell you, we'll start off with how they tend to define. And if you send to a behavioral neurologist, they really often stick to these definitions. Well, if cognitive issues in Parkinson's happen at the same time in 1 year or close to each other, and I'd like to see cognitive first and Parkinson's second, but all in 1 year, then it's Lewy body. But if it's 1.5 years, that's Parkinson's disease dementia. And this is very frustrating. And you can see I was at a Parkinson's symposium where there was a 4-hour debate. Is PDD and DLB different or the same? And the fact of the matter is that patients prefer to hear that they're not demented and they have Parkinson's disease. They like Parkinson's disease dementia better. So people really cling to this, and it's really semantics. So here's the thing, are we doing people favors? Are we doing our patients favors by telling them they have PDD if 1.5 years later or 2 years later they have significant cognitive symptoms? Because if you went to your classic textbook idiopathic Parkinson's patient, you're talking about maybe some subcortical planning and organizational things that people will complain about 5 or 10 years down the road, 8 years down the road, not 1 or 2 years into disease. And this is actually going to move me into which way I'm going to treat somebody, is how prominent cognitive symptoms are. So are we doing somebody a favor by telling them it's not Lewy body because 1.5 years later the symptoms were separated? Also, can we actually rely on patient history? So one is, do retired patients, for example, do they identify their cognitive changes as well? Because, they're the things that they need to do to function maybe a lot less than they were at work, and they have other people around. So these fine cognitive changes, behavioral changes may not be picked up. Do single patients, are they capable of identifying some of the behavioral changes that are happening, depression, even those sort of psychiatric symptoms, are they the best historians? And should we really be even relying on families to tell me that there is early Parkinson's symptoms? So I'm relying on them to identify Parkinson's and cognitive symptoms within 1 year together. And, these things tend to slowly come along. So it could very well be that they were a little stiffer, or maybe they were a little slower, or their arm didn't swing, and nobody thought anything about that as the Parkinson's symptoms. And the cognitive symptoms were floating along, but they were very mild. So it may very well be that these two symptoms happened together. But if the family said they didn't happen together and they happen a year and a half apart, it's not Lewy body. And so these are the challenges that we have. So part of this is, and this goes to what are things that need to be done is, we're finding these things late in the game, and we're relying on patients to tell us these histories. But, we really need to figure out how can we get to Lewy body earlier. There was a study that looked at doctors taking care of patients with Parkinson's and said that even movement disorder specialists, we need about 5 years to be really good at getting it right. Why? Because even when you first see somebody and they have a rest tremor, in those next couple of years, these other symptoms may start to appear. So we can tell if it's atypical Parkinsonism or Parkinson's disease really well after 5 years of symptoms. But in the first couple of years, we can miss because new things appear that weren't there on the first visit. And so we need to figure out earlier, like how can we figure out before that tremor happens or before those first cognitive signs? Because we know that people are losing 80% of their dopamine nerves before they start to have tremor. So what is happening during all that time? And biomarkers is a huge field in Parkinson's right now. And it's something that we want to be able to figure out. How do we differentiate between that Lewy body and Parkinson's patient? Can we get them early? If they have a family member, can we get them even earlier? How do we get to them, and how do we intervene earlier? And can we improve this diagnostic criteria to differentiate between Lewy body from other diseases? Because you can see there's not one specific biomarker, and that a lot of these things can be seen in other diseases. So there's a lot of crossover and overlap. And so every couple years, there's a new Lewy body symposium that changes the criteria ever so slightly. But some of this comes because this is our knowledge of people in real life. Then we take people and they slice brains open. They go, oh, this person had Lewy body. Then we have to go back, and then, historically going backwards, it's looking at a patient through a filter. So we're missing like maybe some symptoms and other sort of things that we don't know because the diagnosis is only happening after everything happened. So, okay, I'm going to walk through a little bit of some of the symptoms, but I should start with some epidemiology. As mentioned, it's not so uncommon. It's 5% of all dementia cases in patients over 75 years. And so there's the prevalence and incidence rates. Certainly the older we get, the more at risk we are. And a lot of the research that happens in my center is genetic. So we have a lot of Gaucher Ashkenazic Jewish research, and we know that the GBA carriers actually often have a Lewy body presentation, and there's various mutations, and some are more likely to present as a Lewy body, and some are less likely. Just because you are a carrier doesn't mean that you develop Lewy body. It's something like 6%. That means 94% of people don't, but 6% do. We see a lot of carriers, and now there is we are in trials working with 2 different companies for intervention to stop the process of this condition. So again, very sort of next phase is identifying genes that put people at risk and understanding those genes better. So one is that there are some new candidates, and one of the things that we are looking for in the future is we're just at the tip of identifying some genes that put people at risk for developing Lewy body. So if we find some, there's probably more out there, and that's going to be sort of that next phase of research. But then, as I told you, just because you're a carrier of something doesn't mean that you develop the disease. So what are the modifiers in these cases? what can maybe we do in life? Is it exercise? Is it coffee? What is it? Are there things that we do that keep people who are at risk from not having the disease? And also there's probably genetic modifiers. There's other genes that you probably inherited that make you more or less likely to express the genes that give you the symptoms of Lewy body. So this is sort of that next phase area of kind of better understanding both the genetic and environmental hits that we have that either make us more or less likely to have this condition. I'm sure this will be addressed in the film as well, but we know that there's a lot of neuropsychological symptoms that patients can have, and they can be things that you see also in a lot of older adults. It's not just, this was a comparison with pre-Alzheimer's patients and pre-Lewy body patients. But when you compare Alzheimer's to Lewy body, you can see that Lewy body patients are much more likely to have anxiety, much more likely to express apathy or indifference, and much more likely to be very sleepy. They can certainly express any of these things on this list, from depression to irritability, but these are things that are a little bit more prominent than we see in Alzheimer's. As I mentioned before, the hallucinations tend to be well formed and mute, so that when they see people, the people are not talking to them. But aside from hallucinations, they very commonly, you can hear stories about having a phantom boarder, or feeling like there's somebody in the house, or feeling like there's just something or somebody around. That's a common report. In terms of the Parkinsonism, as I mentioned, rigidity and the slowness in movement are the most common. In Parkinson's, patients tend to be asymmetric, meaning it starts on one side, it's always more on one side. In Lewy body, it tends to be more often symmetric. Doesn't mean if someone's asymmetric, it's not Lewy body, but it's unusual in a classic Parkinson's to be symmetric. They may very early have gait and balance difficulties, which is something early on in Parkinson's is much less common. Their tremor can be different as well, actually, and as I mentioned, it's less common that they have tremor, and when they have tremor, it can be often mixed. So in Parkinson's, we talk about just this 4 to 6 hertz resting tremor, but they can have tremor not just at rest. You can see it at posture and action. In fact, sometimes we say that there's we can see an overlay of almost what we call myoclonus, which is such a quick little jerk you can't even, you couldn't even repeat it. You'd have to measure it with electrophysiology. But you see patients who look very shaky. So in a Parkinson's, you can see this 4 to 6 hertz resting tremor that looks like this, where in Lewy body, the quality of the tremor can look different. They are more likely to have tremor in their neck than in Parkinson's. They're more likely when they stand to have a sensation of tremor in the leg. And they can even, when they stand, have a diffusion of tremor upwards. So sometimes they just have that very trembly appearance to them, which in Parkinson's we don't see as often. I'm going to try to show you a video. I borrowed it from my colleague who did the first video as a courtesy from me. The other was one of our other patients. And so the video he lent me actually didn't have sound, but you can see that sort of mass faces. He doesn't blink. You can see that kind of trembly action tremor. That's not the classic 4 to 6 hertz. It's kind of like just more fast and frequent. And he would actually have trembling in his chin and his face. And this is another patient who was sort of in that kind of off cognitive, where he was sort of, it almost looks like he was sleeping in this thing, right? But he just kind of zoned out and was out of it. Sometimes actually we have to do a screen for seizures and do an EEG, because the way that family members can sometimes describe it is, oh, he was talking, and then all of a sudden he sort of zoned out and wasn't responding to anybody, and we get worried. We'll just make sure it's not a seizure, which it's not. It's usually part of this condition. So I'm going to move a little bit into treatment and what we do in the office right now. So one of the things I want to emphasize, I probably have it on my to think of slide, but when they do these studies, first and foremost, the studies are done in Parkinson's patients. And then even when we take the essential criteria of Lewy body, which is dementia, the tests, these studies have small percentages often of Lewy body patients, sometimes no Lewy body patients, and only patients who are diagnosed as PDD. And I have to tell you, even though I gave you that cutoff of 1.5 or 2 years, more often those PDD patients are people who had Parkinson's for 10 plus years who go into these studies, and they were clear beforehand, and it's, there's very clear the diagnosis of PDD. So they kind of lump everybody together, and many people in my field would say pathologically that could be true, because when we think about the Lewy bodies, many people, and the reason it gets debated, is it so different, is that many people go with this Brock's model that say that basically we have Lewy bodies. They may even start in the gut and they work their way up our brainstem and they come into the deep areas of our brain and then later into the surface of our brain. That's called Brock's theory in Parkinson's. And their thought is that the Lewy bodies over time, as the load increases, get to the surface of the brain. And when they get there, it's when people hallucinate and can look very much like Lewy body. So the argument is, well, maybe Lewy body, they just have this heavy load of Lewy bodies very early, and they're right in the get-go at the surface of the brain. So now I've saved you like a 4 to 6 hour argument. Pathologically, it may not be different, but lifestyle-wise, it is different because these people went at least 10 years on sometimes lots of other medicines and exercising and working out and doing a lot of other sort of things that may have had a role into their condition. So, in this study, for example, rivastigmine, one of the most common drugs is recommended from the British Society to be used for Lewy body. It's one of the most common drugs that we use is the acetylcholinesterase inhibitors. And here you can see, there are 541 PDD patients. They didn't include per se Lewy body. These are people who had the symptoms of Lewy body. And you can see that when they receive the acetylcholinesterase inhibitors, which increases acetylcholine in the brain, which when it's low can contribute to dementia, improved cognitive behavioral changes, decreased the worsening in their activities of daily living. So basically slowed their impairment of their activities, and it improved attention. And what they notice is that if a patient had visual hallucinations, they tend to have a more robust response. I'll just tell you from like the insider movement disorder perspective, our Lewy body patients, really a lot of times they find the acetylcholinesterase is like miracle drug where they're just so much clearer, so much more attentive. And these drugs are used in vascular dementia. They're used in Alzheimer's disease. They're used you never see those kind of responses in Alzheimer's. In fact, in frontotemporal dementia, it can even worsen some of their symptoms. So getting a very robust response often says to you like, I'm on the right track here. Donepezil, which was a drug that was approved for Alzheimer's first, is another acetylcholinesterase inhibitor. It actually, in their trial, their primary outcome was negative, but then they did like post hoc analysis and went back and said, well, there looks to be some improvement in cognitive measures, and the doctors thought that the patients looked better. Not at the lower dose of the medication, which is a 5 milligram tablet, but at the higher dose, the 10 milligram. And that's usually what we bring people to anyway. I will tell you, again, from the insider perspective, rivastigmine comes as a patch. It comes as a tablet too, but a lot of people get nauseous on these medications very early on, at least. They can build up tolerance to the nausea, but the patch, they tend not to get nauseous because they less GI issues because it's coming right through the skin. So it's nice. It's not another pill they have to take, and the spouse can like slap it on their back in the morning after the shower. And so very, very commonly we use rivastigmine patches in patients. I will tell you that there's some generics that work really well, and there's some generics that are very bad. Like they don't even stick and stay on the patient's back. And I've had someone where they just switched from one generic to another of a rivastigmine patch and just started hallucinating the second that they got a different brand. So that's still an issue now because most patients are getting generic versions of these. Memantine, which is an NMDA antagonist, is approved originally for moderate to severe Alzheimer's disease, but often we'll try it in Lewy body, and there is some some data out there to show that it improves patients overall. It's usually very well tolerated. It can be given either twice a day. There are extended release tablets of these that are once a day. And so then there's other things that we try to do, like cognitive rehab, and there's like no good research. So these are like really areas and, clinically, getting a Lewy body population into cognitive rehab. Does that help? We don't know. We try for everything. We send them to exercise programs because we know that exercise in Alzheimer's is helpful, but we don't really have a group of Lewy body patients who do exercise. I just gave an exercise lecture about a month or maybe in April on Parkinson's and exercise, and there's thousands and thousands and thousands of articles about Parkinson's and exercise, and there's not really anything on Alzheimer's and exercise, but there's not really anything on Lewy body exercise. So we steal, as Norman's amazing resource center has, we steal from Parkinson's, we steal from Alzheimer's, we steal the resources that are out there for them, but we don't have a lot of research that says what happens in our Lewy body patients by putting them in these conditions. So then we go to our medicines, and as I mentioned, we're stealing levodopa. So we have a whole bunch of medications that we use in Parkinson's disease, but a lot of them in patients with dementia, they have very profound side effects, often hallucinations. And so the desire is to try to not worsen cognitive issues, and we're often stuck just with levodopa. And even with levodopa, they can have side effects. And the most common is this feeling of sleepiness or fogginess. So they take the medicine, they go, I feel foggy or sleepy. And really the Parkinson's patients never say that. They just take it. Maybe they feel nauseous, but they don't have that kind of cognitive, psychiatric kind of feeling with it, which we get a lot with the Lewy body. So the Shankerism here is just that my patients actually taught me, which is that there is a generic controlled release or extended release levodopa, and we don't use it very regularly in Parkinson's because you get about 80 milligrams out of the 100, and maybe it does last a little longer, but for patients with Parkinson's, it doesn't kick in. And right away when I started practicing after training, I would say to patients who came in who probably were Lewy body, oh no, like you need to be on the regular levodopa. What are you, much better. They'd come back and say, I felt horrible. I went back to the control release. And so I started putting like the Lewy body patients sometimes right away on the control release. They tend to tolerate it better. And then I'm able to go up on it a little bit more. I don't know why, but for that formulation, it tends to be a little bit milder. So it's definitely a case in which patients taught me what they tend to tolerate better. And so I think I surprised Norma with this at the Sarah Bass. But in 2018, in our neurology journal, was a really interesting trial with zonisamide, which was a medication that has nothing to do with dopamine or acetylcholine. It's a medication that's used for seizures. If you look it up, it'll say mechanism unknown. But we've been using it for seizures for a very long time, Zonogram. And actually, maybe about 10 years ago, there was 2 Japanese studies that looked at it in Parkinson's disease, and they were giving this medicine twice a day and found that patients had more on time without dyskinesias, which is always a worry we have in Parkinson's. And just out of the blue, I had no clue that they were doing these trials, but there was a trial in the States here in Lewy body, and they gave them patients either 25 milligrams once a day in the morning or 50 milligrams once a day in the morning. And they found that patients had improvements in their Parkinson's rating scales with no worsening of cognition. So that's huge because, with levodopa, we worry in these patients about giving them hallucinations, more dopamine, more hallucinations, about making them feel fogged out because it's a complaint they have. And actually, I didn't even get to this, but if you saw that list of supportive things, there was autonomic stuff, so orthostatic hypotension. So there are more risks for orthostatic hypotension, and levodopa can enhance that. So it was very exciting that there was just something else that we could pull out and offer to patients. And I did also have one miracle patient who literally was the last time I'd seen him, he was falling asleep in the waiting room, and woke him up, and he almost fell, and he could not communicate with me. And then the fellow like almost ripped my arm off from my office, like, you have to go see him. And he like threw his walker aside, and he's walking down, and he was talking to me. So we're like, okay, we're gonna stay with this zonisamide too. None of these patients were on zonisamide alone. It was always an add-on to the levodopa. But it's certainly something that now I can say in our Movement Disorder Center, since this was published last year, we've not used infrequently in our patients. We do know that a lot of the drugs that we use in Parkinson's, if levodopa is the safest of them, because give them a dopamine agonist. I just saw someone yesterday who I think has Lewy body. She was told she has Parkinson's, but they put her on Mirapex right away, and she just started hallucinating, and she was cognitively impaired, and she's also falling on somnolence. So dopamine agonist, not great, and the anticholinergics that we sometimes use for tremor, again, more hallucinations and problems. So we really try to avoid these drugs in patients with Lewy body. Again, why early diagnosis is so important, because, to caregivers and family members, to have somebody up all night hallucinating is really, it's distressing. And so you want to be able to kind of already start to think about what kind of medications you're going to offer and how you're going to dose it and how fast you're going to push those medications along based off what you think the diagnosis is. We always try to get patients into physical therapy, again, because the Parkinson's research is there. Patients who get specific fall therapy, so working on balance therapy reduces the risk of fall by about 50%. If they do leg strengthening exercises, that also helps in terms of balance. There's some of these patients have freezing of gait. There's visual cueing exercise. We steal from the LSVT, Lee Silverman, is called voice technique, but they have a think big, which encourages people to take big steps, and it's a specific type of therapy. We send our Lewy body patients to all of these things, and we encourage them to do aerobic activity, because the data in Parkinson's and Alzheimer's really suggests that they might be releasing growth factors and hormones that protect them from cell deaths, like BDNF. And so the recommendations in Parkinson's is 2.5 hours of aerobic activity a week. And so that's what we encourage our patients, because they're often patients who have balance difficulties. I try to push them to things like the stationary bike, because the recumbent bikes have a lot of data in the field. And it's something that no matter what kind of weather they can do. And if they're at risk for falling, they can feel safe getting some help getting onto a recumbent bike and then sitting there for doing 20, 30 minutes of exercise. Also, just thinking about home modification to prevent falls. For example, rugs can be very difficult in patients who have walkers, so having like a wooden floor, and those having rails in the bathroom to prevent falls, having bed rails, so to protect patients from falling off or to help them turn in bed. All of those things are things that we discuss with patients to improve their motor symptoms. So we talked about hallucinations and psychosis. So again, because doctors are getting better, the traditional antipsychotics worsen Parkinson's, and in the Lewy body patients, as Norma sort of alluded, there are cases that ended up in ICUs. So we try to do the atypical antipsychotics. Quetiapine is very commonly used in movement disorders because it's significantly less likely to cause worsening Parkinsonism. Again, not really tested well in Lewy body, but tends to be well tolerated. Clozapine also probably works better than quetiapine, but there's problems with clozapine. You have to be willing to get blood draws every week for 6 months. Why? Because we're monitoring white blood cell count. After you get through the 6 months, then it's every other week of blood draws. And then if you make yourself past a year, then it's once a month of blood draws. And there are nursing services in places like APACS. They come into the home to draw the blood. But you also need doctors who are willing to do the clozeral monitoring. Blast that in our center. We have several people that work in our group that monitor it. But I have psychiatrists who've said to me, I know that clozeral is the best, but I don't do that. because they have to every week. That what happens with these patients is after the blood draw, you have to get the lab, and they won't get their next week of pills until you look at the lab and you give them their blessing. So our nurse practitioner, I see her on sometimes coming in on her vacation, literally to do the Clasral check and then fax everything over the pharmacies and then go. So that's the problem with clozapine. And so all the other classic ones you kind of want to avoid because you're so worried that you're going to worry the other symptoms. Again, the newest one on the market that's used for Parkinson's is pimavanserin. And so in Parkinson's disease, dementia, and Parkinson's, where there's hallucinations, it's this very novel target that's on serotonin instead of dopamine. And it's approved for psychosis in Parkinson's. There is an active trial, I understand, for it in Lewy body. We just really don't know. And I remember Norma saying to me in her group, a couple people were given to it and they had weird reactions. And so I just did have actually a woman who passed away. I had labeled her as Lewy body, who actually the opposite story for me, where basically I had her on quetiapine and we switched her over, and she just passed away, and the daughter basically sent me a letter thanking me because she felt that her personality was more herself on this medication over, and she said, you gave me my mom back from the last 2 years of her life, because she was very like foggy and knocked out on the quetiapine. So I don't know the answer because there's no studies that tell me. So you just pick your poison. This is brand name only. It's expensive. And so you kind of have to, there's a lot of issues that you discuss with patients, especially cost. And so this is always an issue. I should also say that the other drugs, you can start quetiapine right away. Someone calls you and they're like, they think there's bugs on the ground and they were up all night, or they're slashing. I had someone slash their glass living room table with like a hammer. And I can give them some Seroquel and it'll stop it. But this new drug takes 4 weeks to work. So you have to kind of get and they off-label people are cross-tapering. It does prolong the QT. So basically it can have cardiac effects, but so can the other drugs. So they just theoretically tell you not to do both at the same time, but practically most doctors have to try to taper off of one and start the other one. So this is not something that you can start in crisis either. You kind of have to get a sense of mild hallucinations, and you have to basically tell patients that it takes about 4 weeks to work. REM sleep behavior. So actually, again, with Parkinson's, the first line management is to use clonazepam. But in patients with Lewy bodies, actually, they get sometimes more sleepy and foggy on the medication. And so only recently, in the last couple of years, did the sleep docs start to look at melatonin again for REM sleep behavior. And I would say maybe the last 5 years or so, it's become more hot to try it. And just to give you a sense, this is given at bedtime and not at 2 or 3 milligram doses. It tends to be that people who get effect need to be on higher doses. I'm on a committee with one of the sleep specialists at Columbia, and he told me the movement disorder people were shy because we'll go up to 10. And he said they're not FDA regulated. And so a lot of times he has to go up to 20 milligrams a night to really treat the REM sleep behavior. And we don't treat every patient who enacts their dream out. It's really if they're physically very active, or if their bed partner has now left the room, we really want to, make their quality of life better. And so we keep tabs on it. For depression and anxiety, it's really important to monitor for those things. Ask patients. Sometimes they don't think the movement doctor is the right person to say, or maybe they're embarrassed. I have patients all the time who say, you can give me any medication for my neurologic condition, but I'll just take care of the depression myself. And I have to explain to them it's one brain, and the chemical imbalances that cause one thing are the same chemical imbalances that can make somebody depressed or anxious. So, it's like you would never say to me, like, I'll just tell myself to like stop tremoring, but that's how they feel a lot of times about the psychiatric condition. So it's really important that we screen and talk to them about it and normalize it and encourage them to get treated, both with therapy and with medication when needed. And then again, the autonomic symptoms that we see in Parkinson's, we can see in this condition as well. So a lot of times we're managing constipation, urinary issues, and definitely blood pressure issues. So it's really important. Again, sometimes I have to have patients do blood pressure calendars. There are medications that are approved for to elevate blood pressure, specifically for Parkinson's, not really tested in Lewy body per se. And then there's generic drugs like Florinef and Mitadrine that we have used that have not been specifically approved at all for increasing pressure in Parkinson's, but are used because they're generic and inexpensive and work. So again, I mean, one of the problems that we have is that we have all of these drugs out there. We know some of these drugs do work. And so here's the thing is that all of these trials are very mixed, heterogeneous trials with mixed patients. And would be really great to kind of look at patients who very early on have these cognitive motor symptoms and make these diagnoses of probable to see how they respond to these medications to better guide docs. And that's been difficult to recruit and get people early and get people in the time of diagnosis, or people even interested in taking drugs that might be generic already and applying it to this population. And so again, we don't have one drug at all that's specific for this condition. However, there are now in trials interventions for people who are Gaucher carriers with Lewy body symptoms. So that will be very interesting. But the thing is, we really need to have novel interventions, and not only just to treat, but to think about ways that we can prevent the deposition of these Lewy bodies in the brain. And in this case, that's what happened with this guy. He got started on levodopa before I saw him, and he had some improvement, but at higher doses, he was sedated. And we started rivastigmine in the office, and he became cognitively clearer. And we did re-give him a diagnosis of Lewy body dementia. And just finishing up, just thanking Matt Swan, who did give me a couple of his slides and gave me my video back. And just shout out to Dr. Bresman, my chairman, and next to her in this picture on the at your left, is Matt Barrett, who's one of our former fellows, whose research he's now at UVA, has been dedicated to cognition in Parkinson's and Lewy body dementia. So thank you.
Thank you, Dr. Schenker, so very much. I'm sure people have some questions if you won't mind answering them. And I have to tell you, I've heard you speak many times. I've talked to thousands of people and families with this disease, but I keep learning from you every time I hear, and it's always helpful to me. So thank you so much. I'm assuming some people may have questions, and then we'll take maybe a 10-minute break or maybe 15, and then we'll start again. Yes, he had his hand.
So, it was a wonderful presentation. I had a question on pathology. If you don't tell anything to the pathologist, they don't know anything about the clinical case. Can they tell them apart?
Yeah, they can see where the Lewy bodies are, so they can't tell the difference between probably PDD and Lewy body dementia. But again, somebody like, for example, a patient like Robin Williams, where very early in the condition it was he had these symptoms, and to have a brain that early have a lot of Lewy bodies, they would make that diagnosis. So yes, between these and the other pathologies, they would be able to tell if they didn't have much of a story. Yeah, especially because the Alzheimer's pathology is very distinct, and the tauopathy is very distinct from this.
Just sort of a general, so I'm an epidemiologist by training, and I have heard in the last couple of weeks, 20% of all dementia cases have Lewy body dementia. Today I heard 5%. And I suspect that the majority of family physicians who see older adults with cognitive difficulties don't know the difference and are likely not to. I mean, my own mother-in-law had what, in retrospect, seems like it was Lewy body dementia. And when the geriatrician diagnosed her, and I said, I think actually that was Parkinson's dementia, it was 10 years ago, and she said, what difference does it make who it's named after? Yeah. And this was an NYU geriatric psychiatrist. So what I'm wondering is, how do you get data when the majority of cases never get to a neurologist
Yeah, I think you just hit on a really big problem, and I 100% agree. Because some of the data comes from brains, and that's how they make the number percentage, and some is coming from, national reports. And the problem is that this condition is all the things I've said: misdiagnosed, underdiagnosed. Probably a lot of patients do not go for autopsy. Like I've had my patient that is how I got introduced to Norma did go for autopsy. I just had 2 patients this year who did donate their brains into autopsy, and it turned out that it was what I thought it was. But the fact of the matter is that probably I actually spend a lot of time calming my Parkinson's patients down, because family members put in the obits they died of Parkinson's 1 year later, and they go, and I say, I bet you it was atypical Parkinson's. It wasn't Parkinson's. It wasn't a Parkinson's disease. So I think that there's a big problem that's part of the job that we need to do nationally, is to better educate both patients and doctors, because same way we did with stroke, right, is that people didn't recognize symptoms of stroke. So when we made it a brain attack and we started to educate and come up with ways in the community we can teach people, sometimes unfortunately patients teach doctors, and they kind of, once they know that they are even thinking about these symptoms. So I think education on both sides is important. I think it's probably highly underdiagnosed, and that there's a lot of these things come again from brain pathology. So unfortunately, that's something we have to do better at.
I think there's anecdotal evidence that memantine can actually worsen hallucinations. Is this something that you've seen in clinical practice?
No. We haven't really. I always go that there is. But I will tell you, you'll see that it has in the Lewy body consortium. They say it might possibly help. For frontotemporal dementia, giving acetylcholinesterases can worsen cognitive, but memantine in general is fairly well tolerated, and in general, I haven't had that experience. But again, every body is different, so it's not unreasonable to counsel somebody. It's possible, but I haven't seen it.
I was just going to ask about the fluctuating cognitive symptoms and whether or not you can pick that up on serial testing.
I think that so it is a problem, because patients come into the office and they're either one way or the other, and a lot of times I see them when they're sharp. If they were totally out, they may not even come in that day. Sometimes when I see it by video, actually, but that's because family members now all have phones and they tape everything, so they go, look at him here, and so it's not so fast that you tend to see fluctuations in the office, like, really with it and getting you, and then really out. It doesn't happen typically over minutes. It tends to be more hours. Sometimes it's even a particular hour where a wife will say they're very sharp, but then right after lunch, they'll be really out of it for several hours, and they seem to pick up at dinner time. But everyone has a different pattern, so I can't say that's the standard pattern. And sometimes people say, I was just about to call you because for the last week he was really out of it, and then he really picked up, and the last 2 weeks have been great. I had a Lewy body patient who was really out of it. Then he went to the opera, and I probably would have slept through the opera, and it really woke him up. And he went to travel to Sweden and all this other thing. So it's kind of unpredictable, hard to just pick a test in the office in these 30 minutes that you can get. That's why I think even these EEGs, we can't bring them in and notice slowing in an area for a couple hours and clear, or else we'd admit them to monitoring units to do that. Yeah.
Peter,
I have a question about the sleepiness, adrenal glands, etc. So my mother, when she was alive, 2 o'clock, all of a sudden she'd go into the zone. The rest of the time she was pretty good. Eventually she went up like a shuffling gait. She lasted until she was 90, though. None of that killed her. All right? So I guess the question is, how do you engage to quote-unquote sleep disorder centers at hospitals and other places, so that, is that a place where people say, oh, they're having trouble sleep? Is that an entry that comes to you eventually? They come through the sleep disorder rep. Is that a
More often now, because in the last 10 years, REM sleep behavior disorder has really, more and more is understood that pretty much most sleep specialists think that if you see REM sleep behavior, it's going to 100% at some point manifest as either Parkinson's disease, Lewy body dementia, or MSA. So I have had, and because it's associated with the alpha-synucleinopathies, and those are the three. So I have had patients where they had the sleep disorder, went to the sleep specialist, and I know at least at Sinai, several emails, like I just saw someone who basically I diagnosed with REM sleep behavior, and I told them that they should get connected with a movement disorder doctor to do a baseline examination and be connected. So I can't tell you that's every sleep doc, but it's everywhere now. It's not even the last 5 years, but it was like poster sessions everywhere. And that's kind of people, I think, do now recognize that someone in their 40s or 50s who has no other complaints, but they get diagnosed in the sleep lab with REM sleep behavior, you have to watch them. So that is, again, probably not every sleep center is doing. And I do wonder if sleep specialists can be pulmonologists or they could be neurologists. It depends on your background. So I don't know if you're the neurologist, if you're more likely to send to the movement group. And if you're a pulmonologist, then you don't. But I would suspect that at least over the past 5 to 10 years, the sleep community has more frequently sent to movement specialists.
So I'm a behavioral neurology fellow at Columbia, so I'm coming at it from like the behavioral neurology side as opposed to from the movement side. So, one of the things that we know from pathology studies is that something like 80% of patients with DLB pathology also have concurrent Alzheimer's pathology. Yeah. So from a diagnostic and a clinical trials perspective, how do we kind of deal with the fact that we have co-pathology that could potentially confound the diagnosis?
Yeah, I was just having this conversation before with our movement group before I came here, and my chairman sent me just a recent thing that said that mostly, with Gaucher, she sent me something that showed that Gaucher Lewy body tend not to have Alzheimer's, that those brain studies in there have been pretty exclusive. But you're right, absolutely. And so the problem is that ApoE may increase the risk. That's the number of expressing. And we have definitely had patients. In fact, we had one that we presented at the Movement Disorder Society, which was a younger guy who had a very, very rapid presentation, but he had very early memory problems too. And what they found was like in the temporal lobe, he was really laden with Alzheimer's pathology, but he had Lewy bodies like all through his cortex. So that's another problem clinically, right? Is that it's very hard to distinguish. You see usually the Lewy body features, but my gut and what I say now is anytime I see someone who's pretty rapid, I'm like, I want to see their brain. I wonder if they have Alzheimer's pathology too, because we do know that they are sometimes running together. Yeah, it's tough.
We'll take one more, Mary, and then we'll.
So if I were going to advertise Lewy body dementia lobby, whatever it is, it would seem to me from what you said that there are more medicines that are effective in treating the symptoms, both cognitive and other symptoms of Lewy body disease than of Alzheimer's disease. So if you were going to err in the direction of treatability, wouldn't you try those medicines if you had any doubt about which of those two illnesses the person had?
Yeah, but I guess here's the problem is that you're right. First of all, they're the same drugs. There's no like separate drugs. We're using the same 3 drugs. They seem to, acetylcholinesterase seem to be more prominent, especially if there's visual hallucination. So especially I can tell you over the 10 years when I first trained, we gave everybody with a hallucination and like Seroquel, quetiapine. But then when all of this data started coming out with the Exelon or rivastigmine patches, we would give a patch first and the hallucinations would go away. So the issue is, you're right. The problem is that you can't use these medications to distinguish. So in other words, what I probably have a bunch of people who are Lewy body with Alzheimer's pathology too, and there probably are Lewy body too. So that's the problem, is that there's such variability in response. I can't say someone who is robust is definitely Lewy body, and someone who's not as robust has no Lewy bodies because they're sitting there with Parkinsonism and REM sleep behavior and flexion. You're like, oh, it's Lewy body. And so yes, I clinically I'm always like, oh man, because I try not to oversell the rivastigmine, but I tell them it might really make a big difference, and when it doesn't, you're like, oh, that's a bummer because you kind of make the criteria. So you worry that there's dual pathology there. That's the problem. That's even true with levodopa. The Europeans took that out. They used to say, well, if you respond to levodopa in the office, then it's definitely a Parkinson's. And if you don't, but some people are so mild that they don't have a robust response. And some people have lots of tremor, and tremor doesn't have necessarily a market response to levodopa. So we really don't tend to use drug response as the main thing that makes diagnosis. Thank you.
Thank you so much. Why don't we try to take a 10-minute break or even a few more minutes, because everything is right in here. So if you can just get some things and we can sit down, because I know we're short on time and we want to fit in as much as we can. Thank you. As we do that, and people do that because I know they can hear us, and why not? I would like to introduce the next two things you'll be hearing for about 5 minutes each are from two caregivers. One of them will be me, and the other is Paula Sierra, who will be speaking first. Paula took care of her mom, who just passed away just very recently, about 4 months ago. And she cared for her for past 11 years, since she was 19 years old. And so she wants to tell you from her perspective the difficulties and the burden that people with Lewy body families experience because so many people misunderstand the disease. Thank you, Paula.
Okay, hello everybody. Thank you for being here. This is really important for us. To bring awareness, obviously, to the disease, as well as what the families and caregivers go through and the struggles. So as Norma said, a little bit more than 10 years ago, my mom was diagnosed with actually Alzheimer's disease. And I know that that's a commonality, that it gets misdiagnosed. So in the beginning, it was a struggle of recognizing it as Alzheimer's, accepting that it was Alzheimer's. My mom even too, so we were all in denial. It would make my mom really depressed knowing that something was wrong with her and she couldn't really figure out why. Neither could we. And we kept on telling ourselves, but we don't see any memory problems. This can't be Alzheimer's. What is it? So it became even more frustrating. So we kept on taking her to different doctors, particularly the eye doctor. I don't know if you mentioned that, because I know that there's spatial issues, recognizing your space, measuring well where to put a cup. So my mother, she would grab a cup and to put it on the table, she would think that she was going to, but just completely miss. So we thought, oh no, we need to get her new glasses. Something's up with her eyesight. So when we took her to the ophthalmologist, one particular ophthalmologist said, you know what, this is something neurological. So that's why we took her to the neurologist, and that's when she got diagnosed with Alzheimer's. It was a very sad day, but we continued on, thinking that it was Alzheimer's. She had suicidal thoughts as well. She did have hallucinations. She would get angry out of nowhere, so that was something that we had to deal with. She would want to run away from home out of nowhere, so we had to figure out strategies to calm her and kind of, I guess, try to go with her flow and try to put ourselves in her shoes. I can't, yeah. Oh, right. So, I was basically the person to kind of handle all the medical attributes of it all, being that I was the only one that spoke English. So I would say that there was definitely a language barrier. So in terms of resources, that's something that, I hope to kind of expand onto other families of other ethnicities, especially since, we're in New York City. And so I remember one day, about maybe a couple of years after she got the diagnosis of Alzheimer's, we went to another neurologist. And I remember he had mentioned Lewy body dementia. And keep in mind that I'm like fresh in college trying to figure out my life. So I felt like every time that we would go to these appointments and speak to the doctors, I felt like even with the neurologist that said Alzheimer's, with the neurologist that mentioned this term that was so foreign to me and so strange to me, it was all very rushed. We never got an explanation. We never had a sit down. There was never any. I didn't feel any compassion for, especially it being early onset. My mom was in her early 50s, so when I heard this term, I guess maybe I just heard dementia, and I left it at that, and I kept on telling everybody it's still Alzheimer's, guys. I kind of just went over my head. And then 5 years later, about 5 years later, my mom suffered from her first aspiration pneumonia. So aspiration pneumonia is also very common because as the disease progresses, my mom started to have problems with her swallowing muscles. And so we had not realized that we were harming her, obviously not on purpose, we did everything with our hearts, but we were not realizing that, we didn't realize that we were harming her by giving her regular adult food. So we were supposed to make sure that everything was pureed like a baby, like an infant, right? So because my mom wasn't properly swallowing all the food 100%, she would leave some residue in her mouth, and her mouth would always be open too. So I don't know if you also spoke about those blank stares, open mouth, so it would come, there would come a moment where she would just aspirate whatever was in her mouth, and we didn't realize that she was doing that. So instead of it going down the right track, how we normally swallow, it was going into her lungs, and that's how she got the aspiration pneumonia. So in that moment when we learned that, and when she got the first one, she started getting it after that a couple of more times. It was unavoidable. So when we experienced that, we also came to the realization that we take all the minute things that we do as human beings for granted. Because when I started to see my mom progress rapidly and worsen, it was just the simple things like breathing, having your mouth closed, blinking, swallowing, so anyway, after the aspiration pneumonia, things became more severe, and that's when I got in contact with Norma, because I felt like things were worsening, so I was kind of really lost, and I needed help, and I was looking for resources to help me. So ever since then, clarity came, and I'm sorry, when she got the aspiration pneumonia, she was in the emergency room in the hospital. The neurologist there mentioned Lewy body dementia again, corrected me and said, you need to stop saying Alzheimer's. This is evidently Lewy body. So that's when I contacted Norma, and everything became clear after that, and better in a sense. So 4 months ago, my mom passed away, as Norma told you. And so if you guys have any questions, let me know. I'll try to answer them in the best way possible. Thank you for listening, by the way.
Thank you. Thank you for being here. It's such a fresh point. I know all that you went through. Yes, did you have a question for her?
Yes, so thank you for presenting. How old were you and how old was your mother when this began?
So I was 19 and my mom was, I believe, 53. Just I remember it being early 50s. Yeah.
Very difficult for all families dealing with that, and her mom had it for many years as well. My personal story, I'll try to summarize, because my mom had it for 18 years, which is not the norm. For those of you who don't know, generally speaking, people say after diagnosis, whenever that is 4 to 8 years. My mom, at 75 years old, had trouble with her checkbook, and she was a whiz at numbers. And so she was, she went, now I'll be blunt. She went to her internist, who told her at 75 that this was a normal part of aging. Very unfortunately, which we all know it is not. I took her to a geriatrician. She was misdiagnosed with Alzheimer's. She was given Aricept, and we went on from there. Every time we went back for a regular visit, I would hear from the geriatrician at that time, and I'm going back quite some time at this point. My mom passed away at 93, almost 4 years ago, so I have seen things change for the positive in some respects, but unfortunately this is still too common. So she had diagnosed with Alzheimer's, and every time we would go back, the geriatrician would say, she stymies me because her cognition is so clear. Because the difference with the diseases are, it's not just memory loss. She was very sharp, and the cognition, and for those of you who may not know this, in a lot of doctor's visits, we call it showtime. They are speaking in the office like there's no problem. Then you can't even tell, because I think they're very bored. They want the attention, whatever reason it is. And that kept going. I wouldn't know how long this was, but I remember answering this when the doctor said it. We're in the doctor's office after every few months, and he said, I want to watch your mother walk. And I said, why? And she was shuffling. He said, I think she has Parkinson's disease. And oh my God, I didn't know that would have been better than her not having Lewy body. Why? Because I knew nothing about Parkinson's disease. It's the way she's walking. I said, she's been walking like that for the 2 years I've been bringing her here. And from then, I can tell you all the things that happened when she was having trouble sleeping, and she was given, I happened to have slept in the same room with my mother for some time at one point when she was having troubles. My mother didn't have REM sleep disorder, but she had restless leg syndrome, which is another sign of it. And I once watched her, it was like clockwork. Every 6 seconds, her leg was going up and down. She also, I just want to add this part. I don't know how often you hear that. It's just an interesting thing to me. While she was sleeping, because a lot of people with a sleep disorder will also talk in their sleep, my mom, at later on mid-stage, sometimes couldn't complete sentences. But when she was in the sleep stage, she's having conversations, laughing, speaking, complete sentences. And I would say to her, Mom, and she'd say, what? And to me, and I don't have any medical background, so this is just from my feeling, she wasn't in a sleep state, and she wasn't in an awake state, but it's almost like there's a different realm. She was half sleeping, half talking, able to do all these things, but she was half there. When she was given, so what I was trying to say is, she never turned in her sleep. She was one of those people who slept on her back. She was given Ambien once, and she was right on the floor after that. I went back, I spoke to them, I took her to Columbia Presbyterian, I took her to Mount Sinai, I continued and continued. I finally heard one senior physician say to a younger one, what about Lewy body? And I looked it up. And I'm not the only one who said this. I've heard many people in my support group say it. I checked the symptoms. She had every single one of those symptoms except for one, the autonomic problem she didn't have. I went back to the doctor. He was no longer there. The head was there. He saw me. And I said this, and I'm saying this, I'm so grateful for all the doctors who do wonderful work and who are able to do this. But the frustration from a caregiver's perspective who knows nothing, when I hear, I think it's Lewy body dementia, I don't use that tone anymore. I said like this, and he did this. Oh dear, that's so rare. But that was over 15 years ago. And I don't think people would get that response, and but I just want to say how difficult that was. And as it went on, now I can spot Parkinson's with one eye closed because now I know what it is. And from researching everything for a year, every single aspect of the disease and caregiving, which is why I started the organization, and someone said to me, why didn't you get a social worker? Well, who knew to get a social worker? And that's why I do the work that I do. But I wanted to say one more thing. My mom was bedridden for the last 8 years of her life, and she lived with me for the last 7. I had 24-hour care. I never thought I would be able to do that in my home. But she was also very physically fit. She only had high blood pressure, which is another factor why people will last long. That's one factor. And the other is when you have excellent care. She did aspirate one day, 8 years before she passed. And a doctor said she has trouble swallowing. Should we put in a feeding tube? And at that point, she was still there. I knew nothing about it, but it was suggested that she get that and it would be temporary. This is a whole other topic, which needs a whole 2 hours, but nobody ever told me or helped me with that feeding tube, and she lasted 8 years with that. It's not something I think she would thank me for. So I say that it's really, really important for anyone who's helping people with this disease or any other to be so informative in every aspect, because once that feeding tube is put in and the doctor says, oh, it doesn't have to be in, you're on your own. So we're all here to say you're not on your own, for all the families that you may be treating, and I want you to know that. And I thank you for listening, and I really hope that you have excellent ideas to help us move forward, and I love collaborating. We love doing that, so anything that you come up with, we're happy to hear. Thank you all. Thank you. Thank you very much. So now we'll start with the roundtables. And did you want to say anything, Dr. Dewan?
If we can have 30 minutes roundtables, please focus on diagnosis, treatment. What can we do to move that forward? How can we socialize what we do know so we don't get the response that we just heard? And then any bold, great, wonderful ideas. And if each table can pick a scribe who can scribble at the back, and then there will be 5 minutes to report out. Okay, let's go.
Thanks. I wanted to add one more thing, just as informational, because I think it's helpful when we were talking about the fluctuations before. My mom, at times when she was bedridden and could only say a few words, there were times where she went with 3 days of sleeping 20 hours a day, approximately, and you think that's the end. Well, this is the next phase, and this is the end. And the 4th day, she'll look at me and say, good morning, and she's back. That happened at least 100 times over several years. And I didn't mention that she was also on hospice 7 times. And so there's so many aspects like that. I just wanted to mention that too, because there's the fluctuations and the difference how the brain reacts it's such a curiosity, I think, to most people, but I just wanted to mention that if it's informative for all of you. Yes, Peter? The support groups, we have one in Manhattan, right at Dr. Schenker's office, at Mount Sinai. Right in her office. We're also starting another one in September on the west side. That hasn't come out yet because we see how much need there is for it. We have one in Westchester County at the Montefiore Center for the Brain Aging, and we have Westchester County, one in Nassau County, and one in Suffolk.
I think in our group, we were focusing mostly on the questions of how do we improve diagnosis and how do we improve treatment, which were some of the things that we were tasked to discuss. From a diagnosis perspective, I think one of the things that we started out talking about was the fact that the first person that a patient and a family might go to see is their primary care physician. And primary care physicians perhaps are not as educated on the nuances of diagnosing dementia with Lewy bodies, despite the fact that they're going to be on the front lines. We talked about whether or not something like increasing CME would be an option, but there's a lot of demands on general practitioners' time. And so we thought that that would be a really difficult thing to add on. So one of the things that we were talking about is there a way of creating simple screening tools that can be used by primary care physicians to try and identify people who have cognitive impairment? And one of the things that we were talking about was, it's the Alzheimer's Association conference is happening in LA this week. And one of the things that people are working on is trying to develop a pen that can, for example, monitor patients' movements as they draw a clock or sign their name or something like that. And perhaps you can gather information from something like that to try and figure out when people have an underlying neurodegenerative process. We also talked about creating, like, for example, wearables that people can wear when they sleep that can show up, that can detect early signs of REM behavior disorder. And perhaps these are ways of trying to gather information to help with diagnosis that don't increase the demands on primary care physicians' time. The other thing that we talked about is whether we can optimize information that's entered into EMRs. So, for example, if a patient sees a person for memory problems, and that doctor enters dementia into the chart, can the EMR then mine other diagnostic information that has been entered to suggest maybe you should think about DLB, or maybe you should think about doing additional diagnostic tests like a DAT scan or an MRI? From a treatment perspective, we talked about the need for better biomarkers. I think this always comes up when people talk about treatment. You need to know what you're treating before you're able to effectively treat it. We also talked about ensuring that patients and primary care physicians have access to a registry or a list of specialist physicians that they can refer to help with diagnosis and also enrolling in clinical trials and getting appropriate symptomatic treatment. And then the other thing that we had talked about is that until we have better biomarkers and diagnosis is easier, perhaps instead of focusing on specific treatments for specific diseases, we can talk about identifying common or shared pathways between multiple neurodegenerative conditions so that the underlying diagnosis matters less, and you can basically say we're just going to try and prevent neuronal loss.
I missed part of that because I forgot Dr. Schenker needed to be on a conference call. I don't even know how she fit this in today, but I'm glad that she did. I heard about the CME program. What this wonderful table came up with, it seems to be the same thing. I'm sorry I didn't hear all of the rest. But to develop a CME program specifically for Lewy body dementia for general practitioners, it seems to be the best, as Dr. Middleman said, so that we can get to as many people as possible and more people can, they're the people that everyone sees first. And if we can do that, she said, there's a lot involved with it, which most of you know better than I, and that it's expensive, but I really think we can do it. And I think we need to do it. So I'm going to start looking into that with whoever wants to help me. The other thing was mentioned about possibly having scholarships for geriatricians. We know that more geriatricians are needed, and a lot of them don't come into the field because they're not even being paid enough by Medicare and because of payment, so that could be helpful. And then it was mentioned, you should probably mention this better than I, but to stress comorbidity, that over 50% of Alzheimer's patients have alpha-synuclein accumulations, which is, a molecular biomarker for Lewy body, and we can stress that. I don't have a medical background, so I have trouble with that, but with some of that. But that was a good stress. We may be able to use that to go forward to get people's attention. And I think that's it. Any questions? I don't think so, so I'll pass it on. And quality of life intervention, because we want to help as many families as we can, and that's a whole other topic, but to work on that as well. Thank you. Yes, Peter?
One thing we also talked about was the fact that, one of the things we talked about was that dementia itself is stigmatized, and it's just this huge event as opposed to being a disease, and that, everybody shies away from it because God forbid you admit you have dementia or something else. And so it becomes this huge, the elephant in the room, as they used to say, right? And so there it is out there. So even patients themselves say, well, that's the last thing I want to have diagnosed is I have dementia. I'd rather just be considered, they're a little forgetful, rather than I'm actually broken, right? So, I mean, that's sort of, and that's a very loose generic term, but that was one of the things the doctors talked about.
So we had an interesting table. We had Dr. Shanker and then a lot of communications type people. So I think our approach was a little bit different because it just was a different sort of group. So one of the first things that was discussed is the possibility of putting a task force together that includes people that are decision makers, like government people that make decisions, insurance people, maybe SUNY, because that can get a whole bunch of people that seem to sometimes put limitations on what's allowed for doctors to do, get them all in a room and explain those things to them so that they can actually come together and understand more what the problems are. Dr. Shanker talked about the possibility of having a registry of Lewy body patients. That way there was a group of patients that pharma could tap into in case they wanted to do a study of some sort instead of trying to do that in a different way. That would be, I guess, that there's some other diseases where that is what they do, and it makes it easier for them to come find a group of people to do research with. Another one was building financial incentives for doctors to spend more time with patients, because we kept hearing at our table about how you are forced to kind of rush people through, and these sorts of diseases with dementia and all these different ways that it presents itself is very difficult to do in the short amount of time that you're allowed to use with each patient. So those were the, I think, overall ideas that we had. Did I miss anything? Right, yes, because again, we have communications people at the table. Trying to get communication out not just to doctors about diagnoses and things, but also to the general public. I mean, I'm a layperson, and this is the first time I've ever heard of this. And I'm sure that that's true for many, many people. So trying to come up with some kind of campaign that is across the board for people to understand that this is something we all should be aware of.
Thank you, everyone. I wanted to point out there was one more thing that we said too. Of course, there's always one more thing I have to say, is that there's always a need to see a doctor right away when people are having hallucinations. Sometimes they become very aggressive. It could be from medication or just part of the disease. So they'll call our helpline or they'll call me and say, where can we go? And unfortunately, most of the experts in the field have a 3, 4, 5 month wait period. Part of what we need to do is find out who can people see so that they don't have to go to an ER, which is the last place you want to bring a person with Lewy body. So that's another factor I wanted to address, because I see on there about a registry list of specialist physicians. I just want to say on our website that we do list physicians, particularly in New York, who we know can diagnose it well. I just wanted to mention that. And the other one is, you mentioned putting a task force together. I would love to work with whomever wants to do that, to put that together, to put the CME program together. Whoever wants to do that, please let me know, because to me, I don't like to wait on things. Everything, it takes a very long time to get things done, so I want to start everything People say Norma wants things done yesterday. No, I don't. I just want them today. So I don't want to wait much longer. I want to thank all of you for being here. It's really important to me personally and to our organization. I want to thank SUNY for doing this, and I look forward to collaborating with all of you, and really I'm very grateful for you to be here. As a reminder, in 20 minutes, there is a cocktail reception on the sea level. So you'll take the elevator downstairs, and the reception is right there. Susan Schneider-Williams, Robin Williams' wife, will be at the reception, and then she will be, after we have the reception, we'll be having the screening. I'll be talking for 5 minutes again before the screening for the rest of the people who don't know anything, and then we're showing the film, which is about just over an hour and 20 minutes. And then there's a Q&A with Susan Schneider-Williams and director Tyler Norwood. And so that's the full program. I just want you to know, and I hope you find the film powerful, enlightening, and enjoyable in some respects. Thank you all again.
Especially, I'd like to welcome Susan Snyder-Williams. Where's Susan? Oh. And personally, thank you for sharing Robin's story, your story, with all of us tonight. We're honored and we're just thrilled. And then also want to recognize Norma Loeb. Where's Norma? Norma. Oh, thank you. So Norma's worked diligently with our team members here, and so where's Johanna and Sarah and others? Oh, over there. Thank you very much. And I think we're really going to enjoy this evening because of your work. You know, conversations about dementia take many forms, and we're still discovering, I think, just how, just what those conversations about. I had a chance to speak with Susan a little bit, that I helped take care of my mother at the end of her life. And she had dementia, as we all know. It's a syndrome made up of other, underlying diseases. And doing a little bit of work for these prepared remarks, which now I'm not going to talk about, I didn't realize that 50 million individuals worldwide that we know of have dementia. And then, Susan and I had a chance to share that so many other lives are impacted because of the caregivers, the families, the lives that are cut short. So this is a worldwide, obviously, medical issue that's growing, and we need to address it. So what I'm thrilled about is to have the opportunity for the State University of New York to gather people together, because it's about research and it's about sharing information, and it's how we cope and how we move forward. So we have here tonight our interim president, Dr. Mantosh Dewan of Upstate Medical University, who was also here earlier today and helped host some of the symposium and the panel discussion around this very important issue. Dr. Mantosh probably has the best credentials for a presidency because he is a psychiatrist. And so thank you very much. We also have the Dean of the College of Medicine, right? Julio Vicinio, who's here also from Upstate Medical University. And but SUNY has 64 campuses and 1.4 million students and 32,000 faculty. We are the largest, if we were a private organization, we'd be the largest employer in the state of New York. This is an army, and we're here to galvanize that army to come together to help address this issue. And I know our students all over the campuses want to be part of this. So it's not just the work that's going on at Upstate or Downstate Health Sciences Center or Stony Brook University. All the students are ready. I love big problems where we can get this army together to address. So just want to again say thank you for being here. I know it's going to be a fabulous screening, and I just look forward to a long and enduring partnership. So thank you. Thank you for being here, Dr. Dewan. Thank you for being here.
This brief, but again, on behalf of SUNY, we're delighted you're here. We are absolutely delighted that we have a chance to premiere in the medical setting this movie, which we are all excited about. I think this is a very special event, and unfortunately, I just see the person who put it together, Johanna Kendrick Holmes, go up the stairs. I guess she's working, but she's done an amazing job of putting both of these programs together. I also wanted to recognize and acknowledge the person who's going to speak next, but Norma Loeb is really an inspiration and a force behind this. She is the founding director and now the executive director of the Lewy Body Disease Resource Center. And is really remarkable. So we're very happy that she's been part of this journey and a very good partner. I'm going to acknowledge two people who are not here, but we will meet them after the movie. One is Robin Williams' wife, Susan Schneider-Williams, who is, the force behind making the movie. And we also have the privilege of having the director of the movie with us, Tyler Norwood. And after we see the movie, there will be a chance to ask them questions, discuss it, and get their viewpoint. So we're really in a very privileged setting today. I just want to mention that Lewy bodies were discovered over 100 years ago. And even today, many people, including some people I spoke to at the reception, had never heard of Lewy bodies until today. That's pretty sad, but even more difficult is the idea that many doctors don't quite know enough about Lewy body dementia. And everything gets subsumed under either Alzheimer's or Parkinson's disease. So it's something that we really need to work on. So there's a lack of awareness, there's misdiagnosis, which really causes difficulties for the person because the treatment then is not accurate and sometimes harmful. So today's program was put together in two parts. The first was a sort of an academic symposium, 2.5 hours this afternoon, where people came together to talk about, learn, and talk about how we can do better with socializing the idea of Lewy body dementia. I think that was very helpful, well attended. The discussions were terrific. So that was step one. Step two is the movie that we will be showing now. And I think that serves what I think is a very important part that should not be missed. And probably the most famous US physician, also from the early 1900s, William Osler said, "Ask what person the disease is." Ask what person the disease is. And that is exactly what we're going to be doing with this movie. It will be the person behind the person, the patient who has Lewy body dementia. So Robin Williams was, as you know, not diagnosed whilst he was alive. And this is our attempt to explain both the science and to socialize that, but really to also emphasize that people get diseases, people struggle, people suffer. And again, you'll hear from Norma, her very eloquent view of how the family struggles as well. So again, we're delighted with today. I think it's a real privilege. Thank you all for being here. And I'm going to turn it over to Norma Loeb, who is this amazing person.
Thank you very much, Dr. Dewan. We are really, really pleased and excited to host this event for many reasons. Our name of our organization, and I know it's hard for people to remember, so I'll say it again, it's Lewy Body Dementia Resource Center. And it was founded because there were no resources or enough resources for families of members with this disease, and it's so unknown. I'd like to tell you a little bit about that. My mom had the disease for 18 years, which is not the norm. And this organization was founded with my 4 friends and colleagues, and all of us had lost our parents from this disease, and so we know what it's like, and we wanted to help as many people as possible. I will bet that a lot of people in this room don't know about Lewy body dementia. You've heard of it because of this event, but may not know otherwise. So I just want to tell you quickly what it consists of and why it's so important to be diagnosed correctly, because it's misdiagnosed most often than not. It consists of, other than Alzheimer's when people have memory issues, this disease does have memory components to it, but it's cognition issues that are lacking, or executive function, meaning it's hard for regular daily tasks. So it's cognition or dementia plus Parkinson's symptoms. And Parkinson's does not mean just a mild tremor in the hand, which is what most people think, and which is what I thought years ago before I knew better. It's rigidity in the arms and legs. It's slowness of movement. It's a shuffling when you're walking. So this disease affects both the cognition and the movement. Key to this also, different from other dementias, is that there are fluctuations. And people can have a regular conversation with you one day, and later on that week may not be able to answer a question on something that, just a choice of something that you're asking them. That's key to it, to know the difference. They also have hallucinations, very particular hallucinations. Many of them will have of small children and animals. Others become very frightening, and they may need medications for that. There's also an early component, which is a REM sleep disorder, which means people are acting out their dreams. They can punch the person next to them, have nightmares. It's an early sign of it. And there are many more symptoms, unfortunately, such as depression and anxiety. What I want to stress is this disease, though you may not have heard of it before today, is by no means rare. It's the second most common form of dementia, progressive dementia, after Alzheimer's disease. There are more people who have this disease than are HIV positive. There are more people who have this than have ALS, muscular dystrophy, and cerebral palsy combined. So why is it so important to be diagnosed correctly when there's no cure for Alzheimer's or Parkinson's or Lewy body dementia? It's because people with Lewy body or LBD are extremely sensitive to medications. And given the wrong medications for hallucinations, if it's wrong antipsychotic medications, can put them into a coma, can be fatal to them. Other medications can give them hallucinations. So that's why it's so important. That's why we work every day to bring awareness so people don't end up in psychiatric hospitals, and they can get the best care possible. Our resource center has resources of doctors for every single state in the country, as well as for 14 other countries. We have the only live helpline for Lewy body in the country, and we are the first and only Lewy body organization in New York. We also have 5 support groups. I want to mention that in case for any people needing to care for it. So why are we hosting this important event? This film is only the second time it's being shown. It was shown last night at Lincoln Center in the theater at the Walter Reed Theater. This is the first showing for medical professionals, and I'm so proud to be able to do this in collaboration with SUNY, who hosted the symposium and roundtable and this film, because we know that it's important for medical professionals, for all healthcare professionals, to know about the disease. It is the first film ever that mentions Lewy body. And so our hope is that it will be distributed widely eventually so that as many people as possible know it. I want to tell you, I particularly want to thank families and people with Lewy body themselves who have come to see the movie, that it at times may be difficult to watch, but there are very loving aspects as well. So thank you all for coming, and we'll have a question and answer with Susan Schneider-Williams and Tyler Norwood right after. So enjoy the film, and thank you all for coming. I think you probably all need to take a little bit of a deep breath after watching that. I know it's a very powerful film. I'm honored to be sitting here with Susan Schneider-Williams, which of course needs no introduction after watching the film, and with Tyler Norwood, who is the director, and Benson Clare, who's the producer. So we are going to open it up to questions, for any questions that you have about the film. In the meantime, I'll just start with a question or two to get it started. Susan, would you like to say, I think most people wonder a lot of the times what got you two together and what made you do the movie together.
So, check. Hello. Tyler. So Tyler and I met through a mutual friend who was actually my framers for my artwork. And it was my framer who was talking, well, it's such a long story. Tyler had done a film short before called Naples Yellow, and it's a 20-minute film short. And I had found out about that through some interesting circumstances, just an article in a paper, and I was curious. And this was before Robin had passed. And so in that article, it mentioned this framer who became my new framer, and his name is Jim. And then it also mentioned that Tyler Norwood had done this this documentary, Naples Yellow, that involved the framer and an artist and a pigment maker. So I watched it and I was blown away. It was just 20 minutes, but I thought it was incredibly beautiful and well done. And I showed it, I said to Robin, I said, you gotta see this. This is really something. And so we watched it together and he was blown away too. So fast forward, about a year and a half, and everything that you saw happen. And my framer said to me, I think you really should sit down with Tyler, because there's this message needs to be told, this story needs to be told. And so Tyler and I started talking, and his sensibility right away when we spoke on the phone, he had so much understanding and with medicine and also just around medical and also art. And so the science and art was a big thing, and we met and we started talking, and he just said, let's just put a camera on this and see where it goes. And that was about 3 years ago, and that's kind of how it all started. So, and I would also say, I just want to also say that with that makes it sound kind of, what was happening for me personally at the time was, as I was learning more about this disease, it was very clear that this was a very important message, and I wanted to make sure it was handled accurately and with a lot of integrity. And I saw that in Tyler, and so that's yeah, I did. You were it.
Thank you, Susan. I felt so strongly about that too, because you can feel, in addition to learning about the disease and how the difficulties and about Robin's life, but the love throughout. And so that couldn't have happened without you directing it, I'm sure. Can you tell us possibly the parts of the film that you liked the best, or what were most important to you? That might be difficult, but maybe there's...
I think that it's... So the thing with any film is you're sort of like, who are my characters, right? Like, stories sort of reveal themselves, like, oh, I want to do something about this. And you're okay, but who are the characters, right? Like, who can an audience sit with? And so it was like very clear in this that it was going to be Robin and Susan. And it was like, so I had to sort of get to know them. And there was really this moment where just like after doing a lot of interviews with Susan, interviewing Robin's friends, and starting to get this picture of who they were, that like, it just made me smile every time I thought about them. And now you kind of get to know a couple. It like sort of reverse, like through it really the process of the film, right? Where you kind of get to know them throughout the film. Like I had that experience and it was really enjoyable. Like to get to be like, oh, they must have been so much, like some of those photos where they're like dancing and stuff. You're like, that's a cool couple. Like I know couples that are kind of like that, but they don't have all of that. And so just to get to like know them through making the process of the film, like that was great. And you know, because Robin's amazing. Right, like you feel like you know him, you've seen his work, whether you know, it just is in our zeitgeist, it exists. And I loved him as an actor, as a growing up, as a, you know, following the stories that he was a part of. And so to be able to sort of get to know this side of him, and that the deeper I dug with his friends and with Susan, that it just kept coming up that he was this incredible human being as well. That just, I was like, oh, this is, the world's great. Like, this is great. Like, you know what I mean? Like, his story got interrupted, but he's such a cool guy. And like that shines through, I think.
Thank you. I love that scene, by the way, too, the dancing. That was, it was really special. Ben, is there anything, how did you get involved as a producer? And I'm sure you have a lot to say, but are there any particular parts that you want to talk about?
I have worked with Tyler for a long time, on and off, and this was a really exciting project to be a part of. And there's something about this story about grief and how we deal with it that meant a lot to me personally.
Thank you. So I think at this point, I'm wondering if any of you have any questions, if you're ready. Yes.
Wonderful work, of course. And I had a question for the three of you, which is, have you ever heard of Lewy body dementia before this?
Definitely not.
No.
No. Not until the coroner's report.
I actually had a very limited understanding of even Parkinson's, which would be the thing of like, oh, you don't know, right? Like that, there was so much to learn about this, right? That was the starting point.
I have to say that they've learned so much about all of it now. It's been fun watching the passion for learning about this, and again, back to the integrity of behind it, really trying to get the science right. That's been pretty remarkable. Yeah. And so.
Yes. Hi.
Hello.
Just push.
Got it.
Hi. I had a question mainly for Susan. So I know, especially in today's society, there's a lot more focus on mental health and self-care. And throughout the film, I couldn't help but be just captivated by your art and the way that you guys chose to end the movie in that way. And I guess my question had to do with what has allowed you to truly keep working on your art, and I guess having creating such amazing artwork, especially when you're dealing with grief, as you said, and how many people, when things such as this happens, they have different outlets. Some people, when something happens to you, like you lose a loved one, in many ways you stop doing things that you love. So how have you remained grounded in those things and focused on self-care and positivity?
I really love that question.
You do?
Please answer it.
Okay. Wow. So art for me, ever since I was little, has always been my safe place. And I've only been a professional artist for the last 12 years. I went to school for my graphic design degree. I had a 27-year career in that. But while I was doing that, I would paint at night for me. And it's my absolute safe place. It's my escape. And it's where it's just all of that. You know, it is my meditation. And so I think that after a little while, after Robin had passed, you know, I mean, you hear about these things in history with other artists, like, oh, they stopped painting forever, or they stopped for 10 years. And I thought, I really didn't think about that too much, but I kind of wondered, what I'm going to feel, you know, what's going to happen for me in this. And it wasn't too long, maybe, I don't know, a couple of months, where I was able to pick up a brush, and it was slow. And what I ended up doing was this became, and is still, it is what it has always been for me, and it's my safe place. And you know, one of the cool things, Robin knew that for me, and he was my biggest fan. So, yeah. Thank you. Thanks for the
Yes,
question.
sir.
This is a medical question, really. How old was he when he developed visual hallucinations? What were they? And did he tell you about it?
Hallucinations?
Visual hallucinations, yes.
So
How old was he when he first developed them?
We don't know. He never told anyone.
He never.
No, that was from the 4 medical doctors that I'd sent the coroner's report to and the brain scan and what else did I send?
But he didn't complain about that.
No, he did
well,
not.
Let's. So this is a big piece of this film is a journalistic endeavor to try and piece together what we can know. And I would say that I think if we ever really spoke to Bobcat, I mean, he makes a pretty clear case that he was seeing things that weren't real. And I think that was Bobcat being as sort of layperson as possible without having really strong language around it to say, Robin was describing things to me that weren't happening. And so that for me as a journalist, I went, okay, that seems like synonymous with hallucination. So I do think that was happening, but we couldn't pin down a time from Bobcat's reports of when he first would report that was happening. It was only after Robin had passed that he revealed that was something that Robin was coming to him with.
The hallucinations were people, animals, forms?
We can't know. We can't know. But one thing that I did find from talking to Bruce Miller is he said, a lot of times they're irrational fears, but they are sort of fears manifested. It's the things that you don't want to think about that start sort of in the way that dreams can have strange effects, right? And so often they're haunting. They're displeasurable hallucinations, right? Like they're not the kind of things you'd want to have.
Did he complain about visual problems per se, going to eye doctors?
Yes.
Oh, I didn't know that.
There is evidence that the retina,
He
the
had
eye,
he
is
had
involved in diffuse Lewy body disease
the retina
quite early. So I was wondering if he had that avenue explored that he didn't see well.
About 6 months before he left, he had a displaced retina or something. He had to have that. Yes, there was a retina problem about 6 months before he left. And of course, in Lewy body dementia, there's the one of the symptoms is trouble with judging distance and depth, and he definitely had that. He could no longer drive.
Thank you. Yes, ma'am.
Thank you so much for sharing both this important medical information and also more of Robin's life with us. I so appreciate it. I'm not a medical doctor, but I have a related question. You mentioned in the film that towards the end you were seeing a psychotherapist with him every day. Do the normal types of drugs used to treat things like depression, anxiety, paranoia, do they not assist people with Lewy body dementia, or was he simply not using them? Can they be of help in these cases? That was not entirely clear to me in the film, whether he was being treated and it wasn't working, or, is there some assistance that people with Lewy body dementia can derive from those kinds of treatments for
If
things
diagnosed,
like paranoia,
if diagnosed
depression?
with Lewy body dementia, there are drug treatments that evidently can be sort of like palliative in terms of like they're not going to reverse anything, but they can. But unfortunately, since Robin didn't get a diagnosis,
what he was being treated for was Parkinson's. So he was on a Parkinson's medication.
I see.
And because they were treated, they had just begun saying, well, depression as well, and they thought, so they were giving him a small amount of an antidepressant as well. And they were adjusting both of those medications, the Parkinson's and that, and switching back and forth. And yeah.
And
So-
I'd like to say we don't have a medical expert on the panel right now. We have one in the audience, but I won't bother her right now. But what I will say is it really all depends on the individual, because depending on what's going on, every single person with Lewy body is an individual person with Lewy body. It really depends, and you really have to be careful with the meds, and different ones will have to be tried, and there are certain that work better than others. I don't have a medical background either. I've just been dealing with it for so long. Thank you. Anybody else have a question here? Yes.
It's amazing that in this year, those two words, Lewy body, have never been associated.
Trust me when I tell you, you are not in the minority at all, which is why I try to bring awareness in as many places as this, and that's why I'm grateful for SUNY for having this. It's because it's just not known, even though it's not rare, and it's the same way, say, about 40, 50 years ago, nobody ever heard of Alzheimer's. They said senility. Unfortunately, it's taking longer, and until...
It's like having a second moon in the sky. I've never heard of the moon. I mean, but follow-up, was the Parkinson's diagnosis inconsistent with what should have been the treatment if it had been properly diagnosed or diagnosed as Lewy body in the first instance? In other words, was there something adverse about the Parkinson's treatment that perhaps precipitated or was counter to, or?
I just think we're not qualified. Unfortunately, we don't have a medical expert.
Yeah, that's a tough one to answer. I can tell you that the Parkinson's diagnosis was accurate, that he did have Parkinson's, but the overriding, what took him was the Lewy bodies was everywhere. So, yeah.
Anybody else have a question? Anybody else? No? Yes. Oh.
Okay. So you're in kind of this weird space where you're dealing with your grief, and you learn kind of after the fact, you have this kind of aha moment where you learn a little bit more about what caused leading up to his passing ultimately. And because of it seems because of the nature of Lewy body, you're yourself in a constant state of learning about it. And I'm wondering, how do you think, knowing that it doesn't necessarily alter, how do you think that fits within Robin's legacy?
I want to be sure I understand the question. So what fits within the...
So his death, it wasn't kind of a finite thing and you have a clear answer. It's now 5 years on and you yourself are still learning about the details and what it all meant and what he was going through in the And so I'm trying to get is going through this process where you're sharing your grief. It's intensely personal, and I'm in awe of you, quite frankly. And I'm just wondering, how do you think that this is going to impact?
Oh, that's a good one.
Okay, so I have been at this for a while, ever since November 3rd, 2014, when I got the name of it, and it was what Robin and I had been looking for. And so so my learning began then, and I've been on the board of directors at the American Brain Foundation going into my 4th year now. I'm vice chair of the board, and we've created the Lewy Body Dementia Fund there, and also a $5 million research grant award that is targeted at finding an early biomarker. And we've, so far, I'm happy to say we've got $1.75 million in commitment so far. So this could lead to a biomarker, which would mean, we can know definitively while someone is alive that they have it. And so I've been to DC several times. I've worked with a lot of groups and people around the world to raise awareness. So I guess the easiest way to say, if by Robin having had this and by people knowing the truth about that he had this and what it was like, that if that awareness can bring diagnosis and peace and help to people and truly diagnose this. So someone who's got this in their family who's struggling with that if they can have an answer before we did, then that is to me a really good legacy. So that's, yeah, and I've been around the country a lot speaking about it to neurologists and doctors and Johns Hopkins and USC and UC, those places to try and help educate. Because as this gentleman said, you never heard of it before. And it's so shocking. And I was shocked that it was so pervasive and we didn't know. And how could it be in this day and age that something like this exists? So, and I'm not surprised that that so many doctors don't know about it and that people don't. And so how does that change? Well, you talk about it,
Now there's a movie.
And you make a movie. You meet Tyler.
So Susan doesn't have to do it all. The great thing about it is that you guys can now, the next time somebody says, oh man, wasn't that a bummer? Like, Jumanji comes on or Good Will Hunting comes on and they go, oh, wasn't that a bummer about Robin? And you can go, no, you know what, actually, this Lewy body dementia, he didn't get bummed out and kill himself. There was this really interesting story and Robin was actually as good or better than you thought he was. Like the idea that he can be freed up that way and we can all sort of let that out, let a little air out of that balloon, I think is, so that's the cool thing about this is that Susan doesn't have to run around and tell you personal anymore. Hopefully she can take a break and the film can take over with that. And then you guys will do some of that work too.
Thank you. Johanna, yes.
So it's so amazing that we are some of the first to see Robin's Wish. So who else will, what's next? Will it be all over the country? Where are you going to show it?
Yeah, absolutely. So there's all sorts of really great things happening right now. It's all sort of under the sort of NDA in terms of there's a lot of really exciting things that could happen in the next 3 months. We plan for that. We hope for that. Obviously, it's like the Netflixes, Hulus, Amazons of the world doing something really big. So that's all in play. And the other cool thing is because we have such great consulting partners, they're finding opportunities to do screenings like this. And places like the Blue Cross Blue Shield are interested in getting involved. So the great thing is it's a big tent and it leaves a lot of room, I think, for people to get involved and understand. Even if your interest is as a caregiver in sort of any situation, like what Susan went through just as a caregiver, I think is so relatable in terms of trying to make peace with something that is seemingly impossible, right? And just to give more empathy to caregivers and to use this as a tool for that, I think is exciting. So there's so many ways into it, and I'm excited to sort of see the creativity that other people have about that.
Thank you. Why don't we take one more question? Or should I have it? Okay. Yes.
It's not really a question, but it's just more like a comment. First, I want to say it's an amazing, movie. And by the way, I'm assistant professor at NYU College of Nursing. So I think, although I have heard of it, but I don't know so much details of, and this for sure, learn so much and how challenging can be. But the comment I want to have is, I think, please don't forget nurses because they are really at the front line. And you have mentioned, many of the healthcare professionals, they may not know too much about it, but I think that will be a great opportunity to empower them, to equip them to know, because they really contact the patient, the people, and they may help to early recognize the issues, the problems. So that's for sure. I'm a nursing professor, so I definitely want to speak for our nurses and the future our nursing students. Thank you.
Yeah, and we're definitely interested in that because one of the things that's great that we were speaking with some people from the AMA yesterday, and the concept was hopefully if a nurse ever sees someone come to them and say, I'm feeling a little weird. I feel like I might have dementia, Alzheimer's, or schizophrenia. You could be like, I've heard that before. And so that's the great thing is that if that happens, again, towards Robin's legacy, I think that's a great gift that he was able to give us one last time.
And I'd be happy to talk with you afterwards. I've talked to ophthalmologists because a lot of times they are the first people who will see patients and they may not know of the disease as well. They've heard of it but don't know that much about it. And we've been training aides so that they can help families, and we're trying to talk to social workers. We haven't gotten to nurses yet. It's on the list of what we want to do, so I'd be happy to talk if you can tell us how best to do that, please. Thank you. Yes.
I used to work with many, many, many people with Parkinson's every day. We had a big program. We have, it's worldwide. And when the week when everyone heard that Robin Williams died and what the cause was, people were furious. The people with Parkinson's were furious because they know those symptoms before the doctors do, if they get together and they talk together. And they were really upset that somehow the information that is widely known among groups of people with the disease, they know those symptoms, they talk about them, and they help one another. Somehow, what you're trying to do should incorporate groups of people with Parkinson's and Lewy body disease. They know a lot.
I think that's a great idea, and that was part of the research for this film. Actually, one of the days we meant to go to Capitol Hill. There's all that great footage of Susan speaking with Nancy Pelosi on the Hill. We actually got snowed out one of the days we meant to go do that, and we were with all these Parkinson's patients who were going to go up to the Capitol Hill in buses and kind of lobby, and it was this really exciting thing. We were very excited for the visuals of that. And then when they got snowed out, we had a day to kill, and so we just started interviewing them, and they really revealed a beautiful picture of camaraderie amongst those who have this disease, and also an entire side of the psychology of when you have this disease, the way your life changes. And the thing that came through most clearly to me and actually allowed me to connect better to Robin's story was that the physical symptoms were so minor in terms of their interest.
Unimportant.
They were only focused on the psychological symptoms, and that's the thing that kept them up at night, and that's the thing they worried about being a drain to their family about. Whereas, like, they'll push me around in a wheelchair if I need it, but if I can't be who I want to be for them, if they have to wonder if I'm still here, that's the thing that they were commiserating, worried about collectively, and that was great for me, and I think that's an excellent idea.
I think we have time for one more question. One more question, I'm sorry.
In terms of the psychological effects, did you find when they were in these groups and together that it was comforting to them?
Very much so.
To be
Absolutely.
To be part of like a Lewy body group.
Well,
they're
family together because the understanding is
because
so
no one
deep.
else understands
Yeah,
what they understand amongst each
other.
other.
And the nuance of the way they understand the nuances of the disease and how to help each other out of things is extraordinary.
And I think one of the things that we talk about in the film that I'm really proud of is shame, right? Like around neurological disease, that somehow it's very different from a heart disease or, sort of a muscle atrophy. Like the idea that if your brain is breaking down from a neurological degenerative disease, that somehow is on you. And there's a lot of people who get stuck with that shame. And so one of the things that we found really freeing for these men, it was mostly men that I was talking to, was that they could not have any shame as they were describing really painful things that they were going through. So that allowed them to vent and say, this was really scary for me, this was really frustrating for me. And to have the other guys go, wow, like that's really, I'm sorry you had to go through that, as opposed to go, oh, why couldn't you do better, right? And one of the things that they commiserated about was that concept of trying to be who they wanted to be for their partner, because the partner couldn't tell what part of that was the disease and what part was them not handling their disease well. And that was something that really weighed on them. It was a nuance that I hadn't even considered going into this.
Okay, I think we have to close it up now. I know there's a couple of more, but we were supposed to be ending at 9, so I just want to respect that. I want to thank, first of all, our very special guests, Susan and Tyler and Ben. And thank you to SUNY, particular Johanna, for helping to put this together. Could never have done this without you, and thank you for collaborating with us. Very happy, and thank you, Dr. Dewan, for speaking today and for hosting us as well. As you all know, the name of the film is Robin's Wish, and I know we all wish that there a cure for Lewy body dementia, which there isn't at the moment. We hope there will be one in the near future. In the meantime, we are here as an organization, and all of you here together supporting the families who have Lewy body dementia and bringing awareness. And most importantly, is supporting with love, which was shown so much in the film. And so our little gift to you today is a wishing stone that says love, and it's in remembrance of this special event and for our family members who have passed on from it, and also in memory of the love that Robin gave to so many of us. Thank you so much for coming.